Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology, sponsored by EUROTIMES. I'm Boris Malyugin. We're here at the 33rd Congress of the ESCRS in Barcelona. Today, we will be talking about implanting IOLs in the very young with Dr. Vladimir Pfeifer of Slovenia. Vladimir, welcome to Eye Contact.
Thank you, Boris, for the invitation. Glad to be here.
Vladimir, intraocular lens implantation has become the standard of care for the optical rehabilitation of children with cataract from toddler age group and up. However, the use of IOL in implants remains controversial. Is there a consensus of what age you can consider IOL implantation?
You know, Boris, I don't think we should speak about age. We should speak about the pathology of the eye, and we should speak about the anatomy, the structure of the eye. So when deciding if go for IOL implantation or not, we should do a very good surgery. So we should do anterior capsulorhexis, we should perform posterior capsulorhexis, and we should do anterior vitrectomy. And then, if the situation is perfect, then we would go for IOL implantation in a child as young as 2 months of age, or we would not go for the IOL implantation in a child as old as 2, 3, or 4 months, years, you know, because just of the situation that is in the surgery and the pathology of the eye.
Do you think bilateral or unilateral cataract in the child will guide your decision on whether or not to implant IOL?
It's not so important if it's bilateral or not, but the main thing is the situation at the surgery, the pathology, and the anatomical situation. If I have perfect situation where I have all those things that I told you, and I am able to implant this IOL into the capsular bag and perform the optic capture, I would go for IOL implantation. Also in as young child as 2 months of age. We never did younger than 2 months of age.
We know, Vladimir, about the issue of glaucoma, and this is discussed and highlighted in the literature that kids having cataract surgery at the younger age are very likely to develop glaucoma. So any specific recommendations on following this patient?
Yes, we did a study, and we found out that in the cases where we did everything what I said before, implant the IOL into the capsular bag, performed the optic capture, and let the anterior and posterior leaf of the capsule grow together, our glaucoma rate is extremely low. And in the cases where we are not able to implant the IOL into the bag, but we did implant it in the sulcus, we have about 50% of glaucoma. But in this eyes has also greater pathology. And in aphakic eyes, we have glaucoma in 100% of the eyes. But I don't think it is due to the aphakia, but more due to the heavy pathology that the eyes had.
Coming back to the technical issues in cataract surgery in kids, so do you advocate doing posterior capsulorhexis and anterior vitrectomy in all the cases, or only in some cases, a limited one? What is your approach?
I think that if we want to implant the IOL, and if we want to have a true, clear visual axis without secondary procedures, we have to do posterior capsulorhexis, anterior vitrectomy, and we have to use a 3-piece IOL, because this 3-piece IOL allows us to put anterior and posterior capsulorhexis together, and they grow together. And there will be no more lens epithelial cell growth. And also, the Marie-José's lens, back in the lens, does the same thing.
How do you select the power of IOL?
It is a good question. Usually, we go for hyperopia. Depends how old the child is, from 5 to 6 in the year, in 2 months old child, and then later on, we go for less hyperopia. We are looking for to be ametropic at the end, after he is 5-6 years old, or slightly myopic. But this is, there are more factors. If there is lens that we can use, is there such a big power? Is this lens too bulky? There is also a question, what was with the parents? Did they have hyperopia, myopia? So it's a mix of everything.
Great. Who does the surgery? What about your collaboration with the pediatric specialists and you as a cataract surgery? How do you collaborate with them?
I think that surgery on a child should do somebody who is a well-skilled surgeon also in other parts. Let's say in adult cataract surgery, he should know something about vitrectomy. And it should be high-volume surgeon. So in our case, we have a team that decides if we are going for the surgery or not, how is the retina and things like that. And the surgeons who do that, they do a lot of surgeries, adult surgeries and also children. So I don't think that somebody who does 50 or 60 children in a year, that this is a good idea. Then this would be one surgery a week, let's say. And I don't think it's enough.
I know a lot of good pediatric cataract surgeons comes from the adult practice, and that's quite logical.
Yes.
What are the biomechanical properties of the child tissues that you consider most important when doing this type of surgery? What are the challenges in that?
Oh, challenges is very precise surgery. Anterior capsular axis, which likes to run to the periphery, so you have pull very to the central. Then posterior capsular axis, this should be done a little bit smaller, about 4 millimeters than the anterior. So you are really able at the end to do the optic capture. And that's the most important thing. And in our case series, we didn't have any secondary surgeries due to visual axis opacification due to the type of the surgery we are performing.
Do you think femto laser will help us in managing these tough cases?
Maybe it could help if it is possible to do a very precise capsular axis, also the posterior one. And this would be a great help, because this can be a great challenge. If it is not correct, then the placement of the IOL can be a question.
Vladimir, thank you very much for joining us and for your insights on this very important topic.
Thank you, Boris.
Thank you for joining us. For more information on these and related topics, please visit us at eurotimes.org.